still with us. It's an excellent course, and thank you for everyone who's invited me today. I'm privileged to be here. So my topic is about biological fixation, and really this talk is aimed at the trainees. So all the people you've heard speak today have an excellent trauma background and have developed the natural ability to assess a fracture and work out how to fix it. And what I'm going to try and do in this talk is to give you some idea of what's happening in their brains so that you understand why they've made those decisions, okay? So whenever I have a registrar, the first thing I tell them is that failure is instructive. Learn from your failures. You'll learn more from your failures, or when it goes wrong, than you learn from your successes, okay? So one of my jobs in the UK is to deal with similar cases that the previous professors have dealt with, where you have complicated situations where you have to deal with fractures that have gone wrong. And actually learning why something's gone wrong is just as important as how to do it correctly. And a lot of the things we've learned about how we fix fractures is based on when things have gone wrong. So from my point of view, this is a very similar slide to the one in the previous talk. We talk about, whenever we talk about fracture healing or non-union, we talk about the fracture personality, we talk about the soft tissue envelope, we talk about aligning the fracture, we talk about the host, but most of us don't talk about the host because in a trauma situation, there's not a lot we can't do a lot about the patient that's on the table in front of us. And most of the trainees, what they come to first on the list is metalwork. They want to put metal into everyone, okay? But it's important that you learn how to put the metal in properly, okay? So from my point of view, it comes back to basic principles. So there's three essential laws. Wool's law, which bases it on what the normal bone does when it's loaded with, when the bone is loaded. Perrin's strain theory, which is how the bone responds when it's broken. And then the Frost concept, which also talks about how the hematoma reacts when mechanical forces are applied to it. So if you haven't read this is a good article from the UK, which talks about something called the bone healing organ. So it talks about the hematoma as an organ. You need to feed it, you need to protect it, and you need to encourage it to work properly. And if you don't, then the bone healing won't happen and your fracture won't unite. And the principle really of the bone healing organ is that you were talking about strain. So that is the amount of movement that occurs at the fracture. And it's what your consultants and all your professors are really good at when they get a difficult case. They can work out just by looking, just by putting screws in, putting screws here or there, what the environment is that will allow your fracture to heal, whether that's first time or in a revision situation. And that is managing the amount of movement across your fracture, okay? And that varies from fracture to fracture. So the Perrin strain theory, this curve here, is a basic science curve, and you guys will have to learn it for the exam. So essentially there are no numbers on this curve, but what it looks at is the amount of strain, which is on the x-axis running across. And we know that we want around 2% of strain across the fracture, which will allow healing. So that is the apex of the dome. We also know that if you start to get so much movement, so you're at point C and beyond, then you're not going to get healing and you're going to get granulation tissue or you're going to get a non-union. So it is important to try and get the strain environment correct. However, if you go into zone A, where you make the environment so stiff that you put so many screws in and the bone doesn't move, then actually you can get the opposite reaction where again, you get bone resorption and you get a non-union because the fracture is too stiff. So you have to find the balance between too stiff and too much movement. And it's trying to find that 2%. So from my point of view, the bit at the beginning of this curve, which we've highlighted in the top right corner, looks at what happens right at the beginning when you break your bone. So initially what happens is the bone resorbs as a result of the hematoma. Gradually, as the callus starts to form, the soft callus, the amount of bone and the load across that fracture begins to increase, and therefore Wool's law takes place where the bone starts to heal and remodel. And as you start getting more and more less and less movement and the strength starts to increase, then you start getting bone formation. And eventually you'll get to that 2% where the bone forms and remodels and you have fracture union. So I picked this plating system, this method of plating in particular, because this is an area where strain is important. So bridging mode, where we bridge a fracture, is really important. So in this situation, the 4 fractures that I've got listed on the left are identically treated with the plate, but you can imagine that the forces going across each of these fractures is very different. So if we look at the first one and we look at the last one, we would expect there to be very little callus formation on the left, and we would maybe expect lots of callus formation on the right, or even a large bony callus formation on the right. The 2 in the middle, we're not quite sure. We might get some, we might not get any at all. And that is because it's all dependent on how much force is going across it. So when we're talking about bridging mode, a plate used in bridging mode is what I call a load bearing device. So the idea is it acts as an internal external fixator. So with the picture on the right, the pins in the external fixator are like the screws, the locking screws in the plate. And similarly, when you load the external fixator, the force goes through the bone and then goes through the pins, through the X-fix bar, back down the pins, and then back into the bone, and bypasses the fracture. So if you make that construct so stiff that there is no movement whatsoever at that fracture, then you have a problem, because the bone will potentially not heal. So you have to get the balance between fixation and strain, i.e. the stability of the fracture. So when we're assessing strain, we have to look at stability. So we need to decide what implant we're going to use. Are we going to use something that's going to give us absolute stability, or are we going to give us something that's going to give us relative stability? So absolute stability is the kind of simple fractures that we know we can anatomically reduce, we can compression plate, and we can even put a lag screw across, where we've got very little movement, and we're going primary bone healing, and essentially the bone is remodeling. It's not a fracture in effect. We're tricking the bone into thinking everything's normal, and the bone will simply remodel. The other types, where we have load sharing and we have relative stability, then in that situation, we're expecting some callus formation. So we've got our stability spectrum. We've got the cast or traction, where you have relative and you have a lot of movement. So that's why you get a lot of callus formation. Whereas we go to the far extreme, where you've got compression plating and a lag screw, where you've got absolute stability. And the ones in the middle, the X-fix, the bridging plate, the iron nail, all are variable depending on the fracture pattern and how you set those metalworks up. So the idea is that when you treat a fracture, you want to decide right from the beginning, do you want this device to be load sharing, i.e. does the plate take some of the load and the bone takes the majority? Do you want the plate to take more load and therefore the bone takes less load? Or do you want the plate to take all the load and therefore avoid the fracture completely, such as in a bridging mode? Okay, so you need to decide, and the way you can achieve that is by essentially making your construct more rigid, less rigid, and trying to get that balance in forces across your fracture. So this X-ray that I showed earlier, we've used a very stiff device. What you can see is what we call a DCS type device. So it's got a long locking bolt at the bottom, a long plate with lots of non-locking screws. So in this scenario, is this bridging? So actually, this is not a load bearing device. The forces are still going through the bone. So the plate is having to endure quite a lot, and the bone, even though it's being loaded, can't take any of the weight. And as a result, the plate has failed. So the question is, how are we going to try and manage this? So with any fracture, it's a race between the metalwork failing and the bone healing. And this is what we call the SN curve. So the S is the stress. So that's the amount of force applied across the fracture. And then we've got the number of cycles before the plate will break. So if we look at zone A, when we're talking about a fracture, our plates are always working in zone A. Okay, so they're above the endurance limit. Eventually, if the fracture doesn't heal, the plate will fail. Therefore, it is above its endurance limit. So what we want when we fix a fracture is to be able to get as many cycles as possible across our plate so that we give as much time for our fracture to heal. So we want to be where the big star is, not up here where we're only going to get 2 or 3 cycles before the bone breaks. We want to be down here where we get 100 to 200 to 1,000,000 cycles before the bone breaks. And that gives us time. In a similar fashion, if we're down here, it also means the amount of load going across our plate is still above the endurance limit, but it is as close to the endurance limit as possible. If we're up here, we're putting a lot more load through our plate, and therefore the number of cycles before it breaks is going to be a lot less, and therefore we may get a fatigue failure situation where the plate fails. So we want to aim for our fixation to be here. And to achieve this, and the number of cycles and the stress, we have to assess our strain environment. So when we assess strain, as in the last lecture, we need to talk about the comminution, the fracture line orientation, whether it's a segmental type fracture, whether there's bone loss. So as I said, again, with those 4 fractures, which one has the least amount of strain? Probably this one. Which one has the most amount of strain going in comparison is this one. So the question is this the same treatment? It's not. So you have to adjust your fixation method to deal with the environment that your fracture is required. So if you have poor bone quality and an osteoporotic fracture, then you may need more screws because the amount of movement and the amount of force going across your fracture is much higher. Whereas if you have a straightforward transverse fracture, which is axially load stable, then actually the amount of force is going across that bone, it's ready to take that load straight away. And actually you want it to be load bearing as early as possible. And the plate is there just to ensure that that fracture doesn't malalign or displace. So here's an example of what else we need to do. If you don't get the mechanical alignment correct, then the bone will be loaded abnormally, and then your plate will undergo larger stresses. So your plates, particularly on the femur, and I've used the femur as an example, this is what we call off-axis fixation. So the plate is off the mechanical axis. So if we draw the mechanical axis of the femur, it goes from the center of the femoral head down to the ankle. So the weight-bearing axis is here. Whereas with the plate is off the axis. Now that's why the Alizaroff frame and frame surgery is so good. The wires cross through the bone, and actually the central portion of the bearing of the rings is through the center of the bone. So an Alizaroff frame works on axis fixation. So everything is within the bone on the mechanical axis of the limb. Whereas when we're plating, particularly the femur, the bones are off axis, they're off the mechanical alignment. So they have not only an axial load, but they also have a bending moment. So therefore you have a tension side and a compression side. So you have compression and you have tension, where the plate is holding one side open and compressing the other side. So if you get the alignment wrong, then you are exaggerating that deformity and exaggerating those changes in forces, and you are more likely to get plate failure because you're increasing the bending torque and you're changing the tension and the compression side and making them very different. So we finally get to metalwork. So from a metalwork point of view, as registrars, as trainees, we want to pick the method of fixation that's correct. We want to pick the appropriate implant. And the way we decide those is we need to work out the working length and whether it's going to be an on-axis or off-axis fixation, so we can then basically get our strain environment correct. So from our point of view, again, I use the same picture again. How many screws do I need to make sure I get roughly 2%? And the answer is no one knows. Okay, what you have to use is your experience, watching your surgeons, your senior colleagues fix these fractures and understand how they judge the environment. So there's so many variables in theatre, the comminution, the rotational element of it. Is it an oblique fracture? Is it a axially unstable fracture? Is there a large butterfly? All of these make trauma and fixing fractures an interesting career option. That's why we love trauma, because every fracture is different. And you've got to judge every fracture for its strain environment to get that fracture to heal. So as I said, all 4 fractures can be treated with the same device, but need different fixations. So in this scenario over here on the left, with a very stable fracture, you want as less a stiff a construct as possible. So you may even consider not even putting in these extra screws and just sticking with 2 pins above and 2 pins below. And again, that's a judgment thing, assessing the stability. Whereas in this scenario, almost certainly you may want to go with the concept of near and far screws. So if you think about an external fixator, the most stable construct is the longest bar on the outside of the leg with pins far away and close, far away and close. That is a far more stable construct than, say, 3 pins that are really close to the fracture with a short bar. So where the confusion lies is that we use plates with non-locking screws, and we've seen today the brilliant use of blade plates. And in that scenario, what we're using is not bridging mode, but what we're using is a spanning plate that is strong enough to share the load. So in the bridging mode, we're using a load-bearing device. In a non-locking plate, we're spanning and allowing some of the force to go across the plate. So again, we're adjusting our strain environment to make sure that fracture moves enough and heals whilst providing stability. That can only be achieved with the DCS because it's such a stiff, strong bit of metal on the outside of the leg that it can tolerate those forces going across it while the bone is healing. So we've got to decide whether we're going to bridge or span. And the bridging mode, as I said, is all about the locking screws, okay? It cannot bridge if you're not using locking screws. And that's simply the principle, again, of the external fixator. If you were to unlock the nuts on an external fixator and have the pins loose on the bar, that is essentially what a non-locking plate is doing. Therefore, by definition, some of the force will be going through the fracture. So it is a load-bearing, a load-sharing device. Whereas if you use a locking screw, then the forces will go through exactly like an X-fix. It will bypass the fracture and go past it. You want that movement from the plate as you actually load. The working length is important also. So the working length looks at how much of the metal is taking the load, particularly in the bridging scenario. So if you have more plate taking the load, so here's your X-fix, forces coming down, actually loading up the screw across the plate and down again. This, the closest fixation to either side of the fracture, is the working length. So the same as a femoral nail, tibial nail. It's the locking bolt distally and the proximal distal locking bolt. So this is the amount of metal that's doing the work. So again, if you get this wrong and you put so many screws in that your working length is very short, then actually this is an extremely stiff construct, and you're almost down in that curve where I showed you right at the beginning, down at sort of the A zone where you're going to get a non-union. Whereas if you only put one screw in on either side and you have a long plate in the middle with a really comminuted fracture in the middle, then that plate is going to bend quite a lot of load. Strain is going to go up, and we want to doesn't go into the 5 to 10% where we're going to get a non-union. So again, I have that picture on the right for you to think about. How are you going to address your fixation to get the strain environment across your fracture correct, so that your fracture will be mobile enough to heal, but not so mobile that it ends up with a non-union or a fibrous union. So again, the concept of the external fixator. 2 pins very close together with a short rod very close to the fracture versus 2 pins far apart, long rod spanning the whole limb. Again, it gives you the idea that when you're treating a fracture, spanning the whole bone has an effect. It will provide you with more stability, better strain environment. It allows you more options when you put your screws in. So it allows you to create a more stable fixation, particularly in a very comminuted situation. Sometimes the fracture limits what you can do, and you have to think about how you're going to balance your fixation. So when we talk about plating, we want balanced fixation. So we don't want 6 X-fix pins on one side and only 2 on the other, because when you lift that leg up holding onto the bar with a normal external fixator, there is an unbalanced area where you've got good fixation versus none. So you are going to create movement. versus a very stiff segment versus a very looser segment. So similarly, when we talk about distal femur, we have a short segment, or proximal tibia, we have a short segment of bone, but we have the diaphysis below it. So we talk about the number of cortices we use when we fix a plate. So when we do a distal femoral plating, you have unicortical screws distally. So actually what you're achieving by filling the 6 distal screws is you're having 6 unicortical fixation screws. If you then go proximally, then ideally what you want to be using is 6 unicortical or 3 bicortical screws to balance that. So in effect, you've got 6 cortices on either side, so that it's balanced and spaced out appropriately, so you get a balanced fixation. So again, this concept of the working length, the bending across it. If this was a simple fracture, the amount of bend would be very minimal. If this is a comminuted fracture, you're going to have much more change in length, much more bending, and your strain environment's much higher. So you need to adjust your fixation accordingly. Similarly, we talked about on-axis and off-axis fixation. So people find this a difficult concept to understand, but again, basic science shows us if you have a reverse oblique or a subtrochanteric fracture, we tend to use a nail. The reason for that is the nail is in the center of the bone. It is designed to deal with the torque better because essentially it's closer to the center of rotation on your pivot. So your DHS is much further away. It's got a bigger lever arm, and therefore on a seesaw, when you load it actually, it's less able to deal with the torque because the lever arm is so much longer. The nail, the fulcrum is moving closer to the center of rotation or the load, and therefore actually it's far better at dealing with torque. So again, when we're fixing femurs, whether it's proximal or distal, with off-axis fixation, we want to make sure that we are dealing with the torque forces, i.e. get it reduced, get the alignment right, and that will minimize the amount of rotation you have in your fracture. Always remember, whatever you do, this is the most important thing, okay, which is the soft tissue envelope. So the reason open fractures have higher infection rates, have higher non-union rates, is simply that bone healing organ that I was talking about right at the beginning, that hematoma, is lying on the road. It's not in the bone, it's gone. So you have to preserve this bone healing organ to allow it to heal. So when we do fixation, we don't want to strip the bone. We don't want to lose the periosteal blood supply. We certainly don't want to lose intra-osseous blood supply. But obviously when we do fixation, we have to compromise somewhere. So the decision we have to make is which one will we compromise and how we compromise it. So we are all advocates in AO of thinking about using MIPO techniques. And the principle behind that is simply to minimize the amount of soft tissue stripping, which allows the blood supply to remain. And if you don't have a blood supply, then your fracture will not heal. It's as simple as that. It doesn't matter how well you do your meta work. The soft tissue envelope is paramount. So we go back to this case. So we look at this. So when we look at this right from the beginning, we've got a segmental fracture. So we know immediately this is a high energy fracture. We know that the bone here looks comminuted, so again, high energy. So we've got a big soft tissue injury. We've tried to bypass the fracture with a non-locking device. So the concern here is that the strain environment is too high. The fracture will go onto non-union, and therefore the plate is going under significant stresses. And we're on that curve, not down by the star, but right up at the top where it can't take many cycles before it fails. So overall, we also can say that the alignment probably isn't brilliant either. So it was fixed with a slight angle. Again, that puts torque or bending forces on our plate and causes it to fail. So overall, from my point of view, it's all about this curve. Try and get your fixation down here, get the strain environment right, so the amount of stress going across any fixation method is as low as possible. That gives you as many number of cycles before your plate fails or your device fails. So that's all about assessing the strain environment, assessing a fracture, and making a decision as to how you're going to make it correct for that particular fracture. Thank you very much.
Thank you very much, Mr. Nawaz, for this very wonderful talk, really. It went deeply into the details of the mechanics of the plates, and as you said, it's not about just putting a metal part, but it's just about the comprehensive assessment and proper decision making for this. Dear colleagues, if one of the attendees got any question, we are happy to have the questions. We got the panel here, and we are happy to take the questions from now. Let's start with one question for Professor Assam Sharif. In plating after fixator, do you use graft or not?
No, not at all. We allow the time just for regenerate to mature. An external fixation without plating, we don't put graft. So it's more less demanding to put graft in plating because the plate will afford better fixation than the external fixator.
Yeah, thanks so much, Prof. One question from myself, Mr. Nawaz. So, bridging mode, as you said, let's make it clear for all our colleagues. Does it have to be locked plate, or you can do the bridging mode with non-locked?
So if you're technically bridging, then what you're doing is you're bypassing the fracture. So your device is load bearing. Okay, so the device is taking all the load. And what you're creating in movement is because of axial load, but it's the plate moving. And that creates the movement of the fracture. So that's why it's so paramount to get your fixation correct. If you use non-locking screws, then you're essentially spanning the fracture, and it's a load sharing device at that stage. And therefore, you are getting movement from the fact that the plate is not a rigid construct, but has a little bit of movement in it. So you can get away with that in the upper limb because it's a non-load bearing bone, so you can span. You can get away with it in the femur when you have a strong enough device, even with non-locking, that it can bend whilst the fracture is loaded, because at the beginning, the fracture is completely mobile. So a DCS plate is a very good device because it's such a rigid construct and it's fixed angle. The minute you make that mobile or you lose that bend and that rigidity, then the plate will fail, which is why the DCS is such a good device. Okay, but in the true sense, if you're bridging, it has to be locking, because you're essentially saying, I want to bypass the fracture. I'm bridging it. I'm going over the fracture and bypassing it.
Yeah, thanks so much. Thank you. So one question about the working length. So the working length must be shorter or longer in comminuted fracture, in diphyseal fractures?
So there's no right answer to that. So the answer is, you've got to work out how much movement you want at the fracture site. Okay, that's the key. So if you have a comminuted fracture, but your alignment is perfect, your bone is well reduced, everything's sitting perfectly, and you have screws far away, your strain environment may be perfectly reasonable in that scenario, because you've got perfect anatomical alignment, and therefore the amount of force going over the fracture is minimized by the fact that your bone is so perfectly reduced. If you have a very displaced fracture or very comminuted, and you've got a big butterfly that's sitting away from that, and you have minimal bony contact, then in that scenario, the working length, you would say, needs to be shorter, because simply you've got so much more force going through that bone when you've got your bridge. Does that make sense? So
yeah, of course.
With exactly the same fracture, you can, if it's perfectly reduced, you can lengthen your working length. And if it's not reduced, you can shorten your working length to cope with the fact that there's going to be more movement across that fracture line. And that's experience, and that's what I say to the trainees. That's an experience thing. You look at a fracture, you assess a fracture, and a lot of the panel here, they know, they do it instinctively. They can see it, they understand it, they've got the experience, and they know that they need to put a screw here and they need to put a screw here. But the trainees, they just assume that the consultant does it without thinking. And it's an experience thing that you pick up by dealing with these fractures over and over and over again, and understanding what you feel is the right stiffness, or the right amount of movement in a fracture.
Yeah, and that's exactly applies also to some case of the non-union. If you
Absolutely, it's no
understand,
different.
yeah, deeply the mechanics of the strain environment, you can treat similar things with different options. Example for non-union over nail. In some patient, you exchange the nail. In other patient, you may just add a plate, short plate over the non-union side, or just do the graft. That's why it's very important to
absolutely. So
in
the non-union scenario, you want to make sure your alignment is correct. That's paramount, because then your strain environment is easier to judge. If you've got a malunion, then it's much harder to get that strain environment correct. If you get the alignment right, then a lot of the time, as a lot of the professors have said here, you don't need to bone graft. You just need to provide the right environment. So compression, alignment, and correcting that will get most non-unions to heal. And you don't need extra stuff to help. You just need to get the environment correct, and your non-union will heal, as demonstrated by all of the cases today, showing when you get something that's not quite right, you correct the environment, you get enough movement but enough stability at the same time, and you get the alignment correct, the fracture will heal. That's the key. So non-union is exactly the same as a first-time fracture.
Exactly. It will be some repeat, but just make again the difference between spanning and bridging. One of our colleagues asked me about it. So
okay,
it may be a bit confusing for them.
Okay, so spanning, so it basically comes down to whether the plate is load bearing or load sharing, okay? If it's load bearing, i.e. the plate takes all the load, then it's in bridging mode, okay? It's an external fixator. And if it's load sharing, i.e. there's force going across the bone, i.e. the bone is moving as you load it, which is what will happen with a non-locking plate, then that is a load sharing device, and therefore it's a spanning plate.
Yeah,
that makes sense?
That's quite, yeah, that's quite clear. One good question about the load strain cycle. If after the fracture heals, do you still worry about the plate fatigue or failure? So
no.
Can you just tell the patient to live with the plate, or you still worry about it?
So because once the bone is healed, the plate is not being loaded. So at that stage, it's not on the stress strain curve, it's off, because the bone has essentially taken over, the plate is redundant, and the bone is now taking all the load. So essentially the plate is not even on that curve because it's not having any stress on it at all. It's off the bottom, it's zero stress. So it's not on the curve at all. It doesn't take any load.
Yeah, that's why when we look at the x-ray and find the plate is broken, so definitely the fracture is not united.
It's not united, and then you need to look at your biomechanics and work out why the plate has failed. So something is not right. Alignment, strain environment, maybe or the bone, there's dead bone, there's a big gap, whatever, but there is a reason it's gone, and you need to find that reason. It's judging what's gone wrong and how then you're going to address that is the key.
So DHS, is it sharing or bearing device or both? So it's
both. It's both. It varies. Again, it varies, right? So, but technically, it's a load sharing device. But as I said, when I talked about that spectrum of stability, okay, you have completely absolute stability, and you have relative stability, and your fixation methods in the middle have a bit of both. Okay, so certain devices have a combination of absolute, a straightforward intertrochanteric fracture with compression is almost absolute stability. You very rarely see callus on those, right? They heal. But some of them you'll see lots of callus because they're either slightly shear or they slightly rotated, and therefore the load is different, and you'll get callus. So actually, the bone, the fracture will determine your stability, the strain, and whether it's load bearing or load sharing. It's basically, which is why we spend years trying to do trauma and trying to learn how to fix these things.
Yeah.
Okay.
Bridging segmental fractures. So it's a question about shall we fix this segment in the middle when we are bridging segmental fracture, or?
So again, it's talking about the principles of a segmental fracture. So the paramount thing with a segmental fracture is to not disrupt the blood supply, because it's been injured both above and below, and that segment is in trouble. it's got a big soft tissue injury. So whatever you do, you've got to make sure the environment is correct to allow you for those fractures to heal. So you have to get stability, and it's hard in a segmental fracture because you've got two fractures treated with one plate generally, which means that one is likely to go on to non-union, okay, in a segmental fracture, because you will get the forces across one correct, but the other one will, it's a bit like trying to compress a segmental fracture with one plate. One will compress, the other one won't. So the other one has got the wrong environment. So in a segmental, you basically have to balance up whether or not you disrupt the soft tissue and go for stability in that segment, or whether you think that segment's so big that actually you can just bypass it and you've got relative stability. Again, it comes down to comminution, doesn't it? And how you're going to address your strain environment. So yes, if it's big enough and you don't disrupt the soft tissue, you can consider putting a screw across it. But most people would consider just bypassing it, NEPO, and making the top and the bottom X-fix pins or the plate stiffer, putting more and more screws, just sliding the plate in and then screwing at the bottom and making that stiffer. So you've got a longer working length, but you've got to make sure that it's strong enough to deal with the fact that you've got movement in the middle. So at that situation, you put more screws in top and bottom. Your X-fix pins are further away, but you've got a long rod. So you've got to put more pins in to provide stability. You've got a bridge.
Yeah. One question for Prof. Gamal Hosni, but I'm not sure if he's still with us or not, but I will answer the question. It's about the corticotomy first technique. Why don't we do the debridement before corticotomy? And generally speaking, we start with the contaminated. We start usually with the clean part before the contaminated part. So in this specific technique, Prof. Gamal started with the clean part, which is the corticotomy. Then he closed the wound, and then he do the debridement for the infected part. Instead of that, you can do 2 stages, but just the philosophy is that you got many ideas. His main philosophy just for one operation for many various reasons, either social or economic. So usually start with the clean. Another question, it's in case of block graft in non-union, fix it with a plate. Do we need to fix the graft with screws? I think this question for Prof. Sam Sharif. Block graft in non-union. Shall we fix the graft with the screws?
For non-union, if you use the block graft, you need to fix it because it will add to the stability. I think this question should be answered by Dr. Zuhair. He's speaking much about the biomechanics.
Yeah.
I usually fix it.
Thanks so much. I think we're done. The last question, I think it's again specific about one of the cases that Prof. Gamal said. I will not be able to answer it. It's about using the frame to treat the stiff elbow to restore extension. And then would that lead to decrease the range of motion or so? So I think it's a bit complex question for myself to comment. I'm not sure if anybody would like to.
I may have a comment. It's nowadays it is used to treat some arthritis of the ankle to distract the joint. I think on the same principle, distraction with mobilization will avoid some joint replacement for some time. I think this was his philosophy from application of the fixator in the distraction mode, allowing the motion during distraction. And this works in many literature.
Yeah. I think we are done with questions. The last question about the ATLS for polytrauma, ATL advanced trauma life support is just it's a principle, a general principle, and it's a course and principle and philosophy how to deal with the patient, prioritize the life of the patient, airway, breathing, circulation, exposure, and then you look to the fractures and whatever. So as a orthopedic surgeon, you have to do the ATLS course to be able to give the best care of the patient. So we are not treating bones or X-rays; we are treating patients. That's why it's very important to give to have a holistic approach for the patient. We're done with the questions. Thanks so much, Prof. Ashab, to conclude the session today.
Thank you so much, Dr. Ahmed Al-Sheikh. Finally, we come to the end of this very fruitful and scientific night. I would like to thank all our eminent speakers tonight Professor Adil Al-Adawi, Professor Gamal Hosni, our eminent star, Professor Assam Sharif, Professor Sofian Al-Kallal from Tunis, and many thanks to Mr. Zuhair Nawaz from UK. Many thanks to all of you for joining us tonight. In this course, the first 2 weeks will discuss all the general topics regarding trauma. Then we will continue with the upper limb, then the lower limb, then the spine, and then pediatric trauma. See you tomorrow, inshallah, at 10 p.m. with another 2 lectures, 2 very valuable lectures. The first talk will be presented by Professor Mahmoud Hafiz from 6th of October University, discussing initial management of polytrauma patients, and the second talk by Professor Adham Sharqawi from Mansoura University. He will speak about compartment syndrome. See you tomorrow at 10 p.m. inshallah. Many thanks to you and good evening. Shukran. Shukran, Dr. Asam.